And I tell residents all the time, if you don't know what to do with a patient, just be there. How are you doing today? What can I do in this 30, 40 minutes I got with you to make your day better today? Hear me correct, and specifically for AAOMPT, you gotta be good at what you do. It annoys the life out of me when therapists say, yeah, so Adrian's just saying we just need to be happy and whatever. No, be good, otherwise you're useless.
Adriaan, welcome to the AAOMPT podcast. Thanks for coming on.
No, thanks for having me, Jimmy. I appreciate being here.
This is the teaser. This is the thing before the thing, because the AAOMPT conference is coming up in just a couple of months. You guys, AAOMPT.org is where people can find more information, and you're speaking there this year. What do you think about that conference? How does that feel? What do you look forward to in an event like that?
Yeah, the AAOMPT conference is, it's really interesting. I'm actually a manual therapist, so this is a background that is actually my stomping grounds. And then you move heavy into the pain world, and it's always good to go back to your roots. I have always loved it. I like learning from them. I like learning at these events, but then also now bringing the pain stuff with us and going, hey guys, manual therapist moving into the pain world. This is maybe how we should look at things. So I love it. I think I'm going to be honest. Sometimes I have a love-hate relationship because sometimes we're stuck in this old manual model, and I think people know what I'm talking about. And on the flip side, we got this pain thing that is cool. It's altruistic, but you got to apply it. So I think this is the perfect venue for it, where we combine a little bit of both of those two worlds. So yeah.
Okay. Well, it sounds a little revolutionary, and that's my first question. You use this phrase, pain revolution. Help describe that and help people understand it so they can either make their own sign and march with you on this pain revolution and its significance really in orthopedic physical therapy, or how and why should people join in on this revolution?
Well, it's happening regardless if people join or not. That's the easy part. In the early 1990s, when I got into this whole world of pain science, people kept saying there's a pain revolution. I kept looking around, where is this? And it was four guys doing something cool. And what's happened now is, Jimmy, this stuff has now reached a scale that is, the tide is, it's coming. There's nothing you can do about it. It's in PT schools, it's in OT schools, it's in medical schools, there's textbooks, it's at every presentation. The joke of AAOMPT is actually the tweet that went out a few years ago and said, I showed up at the AAOMPT conference only to have a pain conference break out. It is now so embedded in everything that it doesn't matter. It's going to happen anyway. So the revolution is really to take what you were taught, your basics, your foundations, which I still think is phenomenal, but then pushing the envelope and taking on the new concepts of pain science is really what it is. It's happening. So in this case, what's the easiest way? Come to AAOMPT, come take the conference, take these sessions that are a little bit on the fringe of pain science versus just orthopedics, right? And I think that is how people start getting into it.
All right, this next one goes more specific. We throw this term around, nociplastic pain. How do you explain it to someone who wants to learn more? Maybe someone who showed up to the AAOMPT conference and a pain conference broke out. How do you describe it, and why is it clinically challenging? Maybe that's why people avoid it or don't understand it.
Yeah. Well, the first thing we do in medicine, if we don't understand something, we change the name. So this phenomenon has been called central sensitization for the longest time I've been around. And in the last few years, the scientists, the academics have changed it to nociplastic pain. Long story short, it's where the central nervous system actually starts driving your pain experience. So we have normal, healthy information coming into the central nervous system that then amplifies this. So now things like light touch becomes uncomfortable, which we call allodynia. We get hyperalgesia. And for the manual therapist, it becomes tricky because I was taught way back dozens and dozens of years ago that when I palpate and poke in areas and people say, ooh, it's painful there, the problem is there. But in these patients, unfortunately, no matter where you poke, it's sensitive because the system amplifies it. So your tests that you use, your treatments that you use becomes a little bit less reliable. In the old days, if I would poke in an area and it was a joint, then that's the problem. But now those tests are not that reliable. So we have to change the way we test you. We've got to change the way we treat you and approach you accordingly. So it is challenging, and it's about 1 in 5 patients, what the data tells us, walk into private practice or outpatient therapy has central sensitization or nociplastic pain, and they are just challenging. The easy thing is, Jimmy, I'll just say this. Every therapist I've ever talked to can sing this song. Where do they hurt? Everywhere. What makes them better? Nothing. What makes them worse? Everything. I'm not trying to be funny about it. I don't make fun of it. I spend my life dedicating, but there's this commonality in the clinic we see. These patients are challenging. We don't know what to do with them. We're not trained well to work with them. And that is why it's important for us to take it to that next level.
Do you see the people that attend a conference like the AAOMPT conference? They're searching for answers to things like this because they're so frustrated by not being able to help those patients when they come across them in their clinics.
Yeah, I would probably say some of them. I mean, that is how I got there. People always ask me, how did you get into pain science? Well, I failed. The tools I had, and I was trained by some of the best people on this planet with the biggest names that people would hang on to, and I couldn't help them. And so we went to this pain side, which made it filled in a lot of the gaps. So I would argue that at Aon, we're going to get people that have maybe tried their tools, they trade, and they've got to a limit. I don't know what to do now. And that's good for you. Aon is also very progressive. These people that attend Aon are the tip of the spear. They're the best of the best. They are people that read. They read our articles. They trust me. They show up and they'll ask me, "Hey, do you remember that paper on line 27, paragraph 3?" I mean, like, whoa, dude, I wrote the paper. I don't even remember. So I think it's a little bit of both. I think there is the I don't know what to do. Adrian, please help me. But there's also the hey, I'm really into this. This makes sense, and I want to take this to the next level. So it's a little bit of both. I don't yeah, I think it's one of those two directions why people would do this specifically. Yeah.
Yeah. Let's talk about a different phrase that I'm not even sure I came across when I was in PT school. Help me understand the concept of high impact chronic pain and how it's emerged really in clinical practice. What is this when this term comes up? Or is this another word that's just been given a new term?
No, this is actually a subset of chronic pain. So, it's not as if chronic pain is bad enough. There's a subgroup within chronic pain that's even worse. And again, I'm not making fun of it. If you read the research, it just says there's a group of people. If you look at 1 in 4 people in this world suffer with persistent pain on some regular basis, and within that subset, there is a smaller subset that this is really impacting them. And there's criteria in terms of how it impacts their function and their ability to literally get along in their life. And so we need to do even more for them. And so if you go search for high impact chronic pain on the internet, you're going to find it in complex conditions like chronic low back pain and fibromyalgia and knee osteoarthritis. And so it's just people that are really affected even more so. I don't particularly care for it. I'll be honest with people. I think, I'm a clinician. I've always been a clinician. I think of the clinical idea. And I just hate the idea of going to a patient and say, it's not bad enough that you have chronic pain. You have the worst chronic pain we've got called high impact chronic pain. Now, I'm not making fun of it. The scientists that do the work, I know who they are. They do amazing things. I think the world of them. I read their stuff. We have not even got chronic pain right yet. And now we're saying, hey, you guys are not getting this right, but you got to do even more for this. I think it's it's tricky, but I understand why they're doing it. There's a subgroup of people that need even more. And that is why they're identified accordingly. And I may be missing the whole point, but I've read as much as I can in it. I'm just a little concerned because in the clinic side, a patient will walk in and say, no, I don't have chronic pain. I have high impact chronic pain. And that's just another set of, it's like I get a very rare case of frozen shoulder. Unfortunately, I think for the patient side, it's a cry for more help. Hey, you guys aren't listening. I need help. So I'm always worried about these labels we add onto it. But
well, that was going to be my follow-up was, do you think throwing an additional label on that helps or harms?
I think it harms. I don't think it doesn't change one bit for a clinician in this country. If a patient walks in the clinic, Jimmy walks in the clinic, hey, Jimmy, what brings you here? I get chronic pain. I know what I can and cannot do with you. An hour later, Jimmy walks in, hey, Jimmy, what brings you here? I got high impact chronic pain. Nothing's changed for me, except for the fact that I'm probably thinking like, oh crap, this is even worse. It's going to be even a worse day in the clinic. Right, it doesn't change. I still have the tools that I have in front of me on a national scale, at a higher scale. You can talk about multidisciplinary, interdisciplinary, but we're not even there yet. So I apologize to people that are listening, that's probably involved in like Adrian or whatever, but I'm a little concerned where we go with labeling, unfortunately. Yeah.
Yeah. It can get counterproductive.
Correct.
I imagine in certain situations. Yeah.
Oh, if I was a patient, I'd be catastrophizing. Like, it's not bad enough that I get chronic pain. I get the worst one there is, right? It's like, wait a minute. It's not that. I mean, there's a lot we can do for you.
So you said a second ago, hey, if Jimmy walks in with chronic pain or high impact chronic pain, you still have the same tools available to you to treat that person. So let's go to tools. And tools are skills and techniques. So you said at the outset of this conversation, you're a manual therapist who, found this study of pain. What specific pain science skills and techniques do you think manual therapists should develop to better manage complex cases like some of them we're talking about?
How much time we got, Jimmy?
Yeah.
Yeah, it's a good question. I think a good start would be to understand pain, to really understand the biology of pain. The biggest thing, the hardest thing in pain science right now is pain phenotyping. The fact that there are different kinds of pain. You already mentioned nociplastic pain. When patients come in, pain isn't pain. There is pain is driven by nociceptive input, which is nociceptive driven pain, which is it's kind of our bread and butter. It's sprains, strains, and stuff. Man, we're good at this. We are so stinking good at this. Peripheral neuropathic pain, which is your radiculopathies, carpal tunnel, whatever. If you understand neurodynamics, nerve movement, and stuff, you'll be okay with that one. And then we get nociplastic. So for a manual therapist to understand, there are really three buckets that people show up in. And for this bucket, we do this. For this bucket, we do that. For this bucket, we do that. In terms of examination and treatment, we've done a lot of this actually at AAOMPT before. This will continue on. It's a lot of this stuff being put out there. But we have to match the examinations, the vigor, the intensity, the duration of our examinations based on which bucket they sit in. The treatments must shift from nociceptive is going to be very traditionally orthopedic based. Jimmy, lay down, crack your back, you sit up and go, oh, geez, thanks, Adriaan, I'm good. I'm going to go home, right? Whereas that technique does not work in the last patient group with nociplastic. You manipulate them and they flare, and it takes a week to calm that system down. Or they say, oh, that was good. Can you do my neck now? And they become addicted to your hand. So we have to match the treatments, especially in manual therapy, because we can often flare them. We can make them addicted to our hands. So it's a beautiful balance, but you must know what kind of pain you're dealing with. Yeah.
Talking about balance, we're talking about pain on a podcast about a conference from AAOMPT with manual therapy. So should it be pain neuroscience education and manual therapy education, or should these things be combined? Should you not be able to separate them?
I think they go hand in hand, and that is exactly one of the sessions we're doing, blending the two. I was in another podcast a little while back, and somebody asked me a question, and I don't know why, but it slipped out. Something they asked me, "How come you're so good at pain?" And I don't think I'm that good at pain, by the way, Jimmy, but it just slipped out. I said, because I'm a good manual therapist. And the host said, well, wait a minute, what does that mean? I said, because manual therapy gave me my basic skill set of reasoning, thorough evaluation, building a connection with my patient, all necessary things I need. And then the pain science takes me to that next level to take the complex patient. Here's the reality. If you only do one of these two, you're limited. Because if you only do manual therapy and you don't care about pain science, what people think, their fear, their catastrophization, you're not going to make it better. Right. And I would go the other side because, Jimmy, I live in the other world where I go to pain conferences where you don't touch people, because if you touch them, they become addicted, whatever. Some of the most incredible changes we see in human beings that come to rehabilitation is with our hands. They want pain relief. Manipulation, if you look at the effect sizes with manipulation, high velocity thrust to reduce pain, that's actually quite significant. I'm a physical therapist, and last time I checked, we don't have a ton of tools to take your pain from a 9 to a 7 in one visit. Manipulation does, dry needling does. There are techniques that can do it. And so if you walk into my clinic and you're really hurting, I need to do something to get you from here to here. And then you go, oh man, that feels better. Now you're more open to listening to, let's talk about exercise and sleep and nutrition and this stuff. So I think they go hand in hand. On the one side, I need to reduce your pain, and manual therapy gives me that part, but also it gives me the basic skill set. I've said this for the longest time. You have no business teaching somebody about pain unless you've made sure they're safe and you do your due diligence. And the only way you can do it is by being a good manual therapist, to go through all my reflexes, my strength, sensation, make sure Jimmy is safe, he should be here, and not see the doctor. You have no business. So you have to have both. And it's unbelievable that people go, it's this one or that one. I don't see how we cannot have these two cohabitate.
We talked about communication, or you brought it up in several different ways. And I'm a person who loves communication and where it comes in, especially in a patient interaction. How can or how should therapists effectively communicate pain science concepts to their patients to help improve treatment outcomes? We talked earlier about maybe there's a line where it's too much, or maybe putting too many words on it. So, when someone asks, how do I communicate this? How much, when, where, all those W's.
And the answer is yes. I mean, Christmas, we're talking about there's 80 million Americans in chronic pain, and we need 80 million different ways of doing it, because they're all individual beings, right? In the most basic way to teach people about pain, there's two ways, Jimmy. One is a technique. I literally say, Jimmy, listen, you're doing great. I'm so proud of you. We're making good progress. But today I need to teach you something very important. So I sit you down and we're having a very deliberate conversation. I need to explain to you why when it's cold, you feel your neck. Nobody's ever done it. So let me do that today. That's one type. And we call that often pain neuroscience education. I sit down, it's almost like a technique. I'm doing this thing, and we have data to prove that your fear goes down, your catastrophization goes down. So it works. I mean, I can actually bill you for it. The other way of doing it, which I find very intriguing, and this is kind of where the research is going, is called pain neuroscience communication. And that is people that we train, and we've been tracking the data in our research, is that if we train people in pain science, they change the way they talk to people. They're softer spoken, less provocative. They stay away from words that harm. They use more calming, relaxing, reassurance kind of. It's almost like you take a shaker and you shake it through the clinic a little bit. It's like you sprinkle this little bit of thing. So we call that pain neuroscience communication, and we're tracking some data in some of our research there. So I think it's both. I have heard people say, Adriaan, I've learned this pain stuff from you. And I find myself, I'm softer spoken. I slow myself down. I make sure there's reassurance. There's all the things that we care about. So it's a little bit of both. Yeah. But I think it's at its basic core, Jimmy, it is reducing words that harm. Therapy has the most harmful words known to man: torn, rip, rupture, bulge, herniate. Take them out of our vocabulary. Use softer spoken words that still explain. I know this is going to be a little blasphemy at AAOMPT, but they have shown us that words like sprain and strain, as benign as they are, they're actually benign. The top of the top manual therapists will say, well, that doesn't really tell people. But the patient studies show us that if I tell you a sprain or a strain, it doesn't evoke fear and you understand what's happening. So we can soften, explain, calm down, reassure. That's why I love being a therapist. 99% of what I deal with is not life-threatening. 99.99999%. So for me to walk up to Jimmy and say, Jimmy, you're going to be okay. I know you hurt your ACL, dude, but guess what? I've seen 100 people like you just last year. You're going to be okay. See the guy on the bike there? It was just like you a month ago. Now look at him. What am I doing? I'm calming you, taking away your fear, your anxiety. Sure. So it's a little bit of those. It's reducing the words that harm, giving information that is understandable, and reducing fear and catastrophization. And it's not necessarily deliberate. It is just we change the way we practice.
You said that people that study pain neuroscience communication, they begin speaking softer. Why do you think that is? I want to take a guess, and you tell me if I'm right or wrong. Do you think now that they sort of, because now you're studying people and not a condition, do you think there's increased empathy? And now that they understand a little more, they're a little softer?
Yeah, we have shown it. We have tested healthcare providers, measure the empathy and compassion, and then we teach them, and afterwards the compassion and empathy changes drastically. We just completed a study on medical residents and did the same thing to show they turned extremely empathetic, compassionate towards people in pain, which isn't that just the coolest thing? So yes, we're focusing on the human being versus the condition, right? But yeah, it's just to understand what they're going through. These poor people are struggling. They've been everywhere. Nobody can help them. The thing about chronic pain, though, Jimmy, is the bar is so low. The good news is the bar is so low.
Meaning what?
Meaning that they have been so underserved. Nobody's done anything for them. But that's the good news, too. And I tell residents all the time, if you don't know what to do with a patient, just be there. Just be there and say, how you doing today? What can I do in this 30, 40 minutes I got with you to make your day better today? And now, hear me correct, and specifically for AAOMPT, you got to be good at what you do. It annoys the life out of me when therapists like, God, so Adriaan's just saying we just need to be happy and whatever. No, be good. Otherwise, you're useless. Your skills must match what you're doing, not only the cognitive side, but the physical side. I mean, seriously, you have to be good. Patients know when you're good. And that's why I love AAOMPT. I love manual therapists, because you've got this side covered. You're excellent at what you do with your hands. But now bringing the soft skill set, that is what's really, really good. A few years ago at AAOMPT in Reno, Bill Boysenholt, who was formerly at UW-Madison, made this beautiful statement, Jimmy, where he said, these things like compassion, empathy, respect, listening, they're not soft skills, they're essential skills.
I like that better.
Yes, me too. And it was an instant, I was like, dang, that is really, really good. They're essential, especially for this population. Yeah.
Bill said it way better. I did a presentation on the importance of soft skills. My background in journalism and communications before becoming a physical therapist. And the title was, why are these soft skills so damn hard?
Yes.
Because some people will say, well, why are they so difficult to do? And you want to talk about words by calling them soft skills, do you decrease or increase the value? Some people say, well, I decrease the value and it should be simple. So I've done it, right? The goal of communications is just to have communicated. No. The goal of communication is to achieve understanding, right? So the fastest lesson that I've ever learned is children and puppies. If you're not communicating right to children and puppies, you will get no result, but you'll say, I just yelled louder and I said it more and they didn't do it. They didn't understand. Right. Because your soft skills were not on there, were not working, because the goal was to achieve understanding, not to have communicated.
Correct. Oh, beautiful. Yeah, I'll have to remember that one.
What should someone look forward to? You have a couple presentations, one's virtual, one's in person, at your presentations. Essentially, Adriaan, I'm giving you first dibs to put butts in seats for your presentation. What are people going to look forward to in St. Louis?
Yeah, so there's two parts to it. One is we have two sessions. One is on blending pain science and manual therapy, which we just talked about. What myself and Dr. Louis Puntadura, my buddy Louis, and I going to do together is basically show the two sides, why it's important to do manual therapy and why it's important to pain science, but then more importantly, how these two work beautifully together.
Sure.
We believe they're not mutually exclusive. And we're going to share that data to show how you can basically, for lack of a better term, take one patient and start the manual way and end up in pain science. The other patient, you start with pain science and end up with manual therapy. They're not exclusive. And you can use them interchangeably for different reasons. We can talk about the words we use. I think one of my favorite quotes my buddy Louis always talks about is, I still do the same manual techniques I've always done, but I explain them different. We don't fix things don't go out of place. We don't put things back in place. We're just getting some nice movement. We're getting things to move a little bit, get some blood flow, oxygen to calm the system. So we change the words, but it's the same stuff. The other one we're doing is on whiplash injuries. There's just, of all the musculoskeletal conditions, that's the one that goes the most into chronic pain, about 40% of people. And some of the amazing research from Michelle Sterling's work in Australia has looked at therapists doing early intervention, psychologically informed care, like reassurance, all those things in the emergency room early on, that actually calms the system beautifully, then allows them to move and be treated with hands-on. So those are the two sessions we're doing at AAOMPT.
Perfect. All right. Last thing we do on the podcast, let's wow them. What's words of wisdom? What's the last thing you'd want to leave with the audience? Is there any idea, sentiment, quote, mic drop moment? What do you got?
Yeah, I should have thought about that one. I think one that's becoming very favorite in the pain world for me is the fact that pain that is understood is not to be feared. The more we teach our patients what's happening to them, the more they calm down, and fear drives pain powerfully. So if they understand their pain, they're not afraid of it, and they will move and in this conference be touched and go, I'm okay. I'm not being hurt. I'm just sensitive. And I think that's a critical element.
Well said. Looking forward to your talks and appreciate the time giving us a little tease ahead to AAOMPT's event.
Thanks, Jimmy. Appreciate it.